Okay, so you wonder how you get into these things. This was a very casual comment to Barbara Cochran, and then she had a wee chat with Evelyn up here at the front, and before you know where you are, you're here. But anyway. But it is something that's really, really interesting, and I've got a bit involved in this because half the time I'm actually doing pediatric gastro, I don't just do metabolic. And so that's really where it came to. Anybody, would we just have a bit of a hands up for people who actually look after somebody on blended diet or have actually put somebody on blended diet? So not very many of you. In pediatrics, I guess the people who've got most to do with it now are people who do home enteral feeding or if you work in pediatric gastroenterology. But I promise you it's going to spread. I think if I asked you in 2 years' time, I think you'll all have somebody at least on partial blended diet. And what's interesting about blended diet is that it's something that's really been parent-led. It's only very recently that it's become professional-led, either dietetic-led or consultant-suggested. And if you just do a bit of the Googling, there's huge amounts of stuff that pops out. And in America, up to 50% of adults who are gastrostomy fed will be having some blended diet. And that's for financial reasons, because they don't get feed and prescription. And of course here, all our feeds are on prescription. So there's maybe not been the same incentive to move forward that way. But in my department, until somebody said there's a delay in this, it's a little bit strange. So as we all know, the BDA doesn't actually formally represent or recommend or support blended diet. I mean, I'm sure that probably will change, and there are working groups and various other groups of people looking at things, but a lot of this work's being done locally within individual hospitals and regions, but it's certainly very topical. I think it used to be very controversial. I mean, I remember when we first had a patient who told us that she was doing this about 10 years ago, and I mean, people were horrified. They just couldn't get their minds around how somebody would do that. But I mean, I think now it isn't controversial anymore, the fact that families want to do this. The three reasons people always worry about it: it's nutritional adequacy, which, I mean, we're dietitians, that shouldn't really be a problem for us. Blocked tubes, which I think isn't actually a real problem as long as it's managed properly. And infection risk, which I think you do have to be careful about. But there is limited evidence. I'm sure, again, we're going to see much more in the next few years. There's lots of people must have case reports to publish, because we certainly have. But I certainly have been most impressed by just improvement in GI symptoms. And I'm just going to show you a paper that's actually shown for the first time the change in diversity in gut microbiota, which probably explains why some GI symptoms are much improved. And then just improved weight gain and well-being. And what you absolutely can't underestimate is the emotional aspects for parents and carers. It's really emotional for families who've never fed their child proper food to give them food. Absolutely unbelievable. And to go out and buy food for their child. Very emotional. So there's a couple of recent papers that would be the two, I think, if you want to read about it, would be the most useful. A year ago in the archives, they looked at a sort of rapid review of blended food for tube-fed children, which doesn't say anything very dramatic, and really just came to the conclusion that there may be some benefits to using blended diet, although the concerns that I've just voiced remain. But it's quite good for references if you're interested. And then this is the more interesting paper that just came out in the summer in JPEN. And this is a study from the Hospital for Sick Children in Toronto in Canada. And they had a structured study where they put 20 children, mostly children with complex neurodisability, who were fully enterally fed through a gastrostomy, and they transitioned them to blended diet. I'm actually going to say I want to call it blended diet because we blend food in this country. We don't blenderize it. So I want us all to call it blended diet because that just sounds better, I think. Anyway, it was Canadian, so it was blenderized. And so it's, again, an interesting paper to read. But one of the specific things they did was they did stool cultures using DNA to look for biodiversity. So looking at the bacterial diversity in the children when they transitioned on to blended diet. And again, it's not surprising. If you're going from just one single formula to a very diverse diet that includes probiotics, prebiotics, fiber, all kinds of different factors, you would expect the bacterial flora to become more diverse. And you do wonder if that's why some of these children have a kind of mild colitis a lot of the time. You know, it's interesting, but that's the only paper I've seen that's done that. It's interesting, I mean, they did it in quite a structured way, and they gave people very specific advice about portions and types of food to use, which I think most people are a bit more relaxed about, but I mean, it was a study, but I would recommend reading that. It was just published in August. So, non-metabolic patients, the ones that started off being on blended diet, mostly have cerebral palsy or other complex neurological conditions, and they're just totally or virtually totally reliant on enteral feeding. And the characteristics, I would say, and I want you to think about your metabolic patients, some of them, they have multiple GI issues, they have problems with reflux, constipation, abdominal pain and feeding. I mean, we would say in gastroenterology, a lot of them have, you know, generalized dysmotility, which eventually, in some of these children, becomes intestinal failure. You know, GI dysmotility eventually becomes intestinal failure if it goes on long enough. Frequent feed changes, often transitions to very expensive feeds, because when things aren't going well, what do? You go from a polymeric feed, you go to peptides, you go to elemental feeds. Probably doesn't make any difference, but we do often step them down again. And they're on so many drugs. 12, 14, not uncommon. So, this is where I work in Aberdeen. We have giraffes in Aberdeen. There's also baby elephants round the corner, but not real, but they were actually blown over. We had a bad storm in the winter, and they were blown over, and they all lay with their legs up in the air as though they'd been shot. It was very exciting. But anyway, I divert. So at the moment, this has probably gone up since I did this slide. We have 5 or 6 children who are fully in blended diet, not metabolic patients particularly, but just all kinds of patients. But we also have a lot in partial blended diet, and I would suggest to you that that's probably the way ahead for lots of patients. And as I said, initially parent-led, and we started becoming involved with supporting families, particularly around getting blended diet into schools and respite, because parents can do things at home, but when the child is being cared for somewhere else, you need a bit of paperwork. So we adopted a risk assessment process for that, and we've done that for many years. But now we're starting blended diet in hospital because it's actually being suggested by doctors, and we've started doing that. And that's where it becomes a bit more complicated, because you need to get some guidance around if you want nursing staff to give blended diet, because they won't be signed off for that. And you need to be able to have a good working relationship with your catering department. But it's all doable. It's just getting on with it. So I began to think, we've got all these patients, super impressed with some of the results we've had with some children in terms of weight gain, improvement in GI symptoms, just the whole benefit that the family have gained from the experience. And I thought about some of my metabolic patients that I felt could possibly benefit as well, because of a metabolic diagnosis, they are being enterally fed. And I picked in a few patients that we had. So I've got 2 girls with propionic acidemia, and like so many people with propionic acidemia, they just pick at food. They have safe swallows, but they just toy with a lettuce leaf or sips of wine one of them likes, and just random foods that's very, very variable, but just tiny, tiny amounts, and they're very reliant on enteral feed. And I've also got a boy with Pompe's who's fully ventilated, can't eat anything, and he's fully enterally fed, but on a normal diet, so he would fit well into that category as well. And I had 1 or 2 others, but the one I'm going to talk to you about is Amy, who is an 11-year-old girl with propionic acidemia. The picture refers to the fact that she always seems to be surgically attached to her tablet, but that's not uncommon. So she's got very complex neurodisability from her initial presentation, very high ammonia at diagnosis. She eats the odd teaspoon of food now and then, but basically has always been fed enterally. She's got problems with gastroesophageal reflux, and she definitely has worsening panenteric dysmotility. So right from the top, so bowels, reflux, and just general pain. So she's got panenteric dysmotility. She's often jejunally fed when she doesn't tolerate gastric feeds, and we've been through so many different feeds, but she's currently on a modular feed based on peptide formula with an overnight feed and daytime boluses. And most importantly for this, she had a 14 French gastric button, because if you're feeding blended diet, you need basically a gastric button. You don't want to be putting blended diet down a peg, because if you block it, it's a bit more tricky to get it sorted out, but at least with a gastric button, it can just be changed. But in my experience, I mean, I cannot think we've ever had anything that's blocked, because the parents are just really good about flushing, because they don't want it to block. And she also has a jejunal button for feeding when she doesn't tolerate gastric feeds. So, quite a lot of chats with her mum, because, you know, things have just not been good. And her main question to me was, is there anything we can do to improve Amy's bowel management? Because she, again, I think lots of patients with PA and related conditions, the parents like them to have quite a lot of bowel movements. They feel they're just much better. She gets very anxious if she isn't moving her bowels regularly. And it's always been a sort of difficult area to just strike the right balance. And also just being very tied to jejunal feeding. She is a wheelchair user, but at home she rolls about and climbs about, and it's much easier not to be attached to anything during the day. So more tube freedom. Could we actually get rid of continuous feeds during the day? And just massive emotional benefits for our mum, because this little girl, it's her only child, and she's never fed in any stretch of the imagination normally. So we had a bit of a think about it, and what I decided to do was, I think, you know, we do need to continue our overnight feed. I don't think she'd manage without that. But we just started doing what we do with all the ones that we start blended diet. We just start with little amounts of low-protein purees. So it is just like weaning. So if you start a blended diet, I just think of it in my mind like weaning a baby. So you're going from all milk, all feed, introducing little bits of food, and then just gradually moving and food overtaking the milk part of the diet. And in a low-protein diet, that works quite well, because you can start off with little bits of low-protein fruit and vegetables, just like weaning a child on a low-protein diet, and that's what we did. We just gradually increased the amount. So we just started with sort of 30 mils twice a day, just a little bit of fruit puree down her gastrostomy, flush of water. Parents are always really anxious something dramatic's going to happen, but, you know, nothing happens. We did that, and we just gradually increased it until she was on 100 mils twice a day. We didn't change the feed at that point. And we just added in a bit of glucose polymer just to improve the calories, because we just cut back on a little bit of our milk feed just to keep our calories up. And all went well. And again, Mum was just very impressed. She felt that what she noticed right away is that her stools improved. They were a little bit less explosive, a little bit less uncontained in the nappy. Things just seemed to settle down a little bit. And so then we moved on to devise some sort of protein calorie counted blends, because if you're not on a low protein diet, obviously you just use ordinary food, and you just either make special blends, which lots of families do, or they can just blend up a part of the family meal. So they would just put in a bit of chicken breast and a couple of potatoes, a couple of pieces of broccoli, a couple of carrots, some milk, and whiz it up. But obviously this little girl's on a reduced protein intake. So along with what her mother wanted to do, we just devised some little meals to replace some of her bolus feeds during the day. So it wasn't very complicated, anybody could do it. So we got these are just a couple of recipes that we devised together, things that she wanted to give her. The single cream's there because in blended diet folklore, you have to make the blend the consistency of single cream. That's just quoted everywhere. So the consistency of single cream is what goes down your tube. It doesn't mean you have to add cream to everything. Although we do have a patient on a ketogenic diet who's on a fully blended diet, and they obviously get quite a lot of cream added to their food. So a couple of examples, a sort of breakfast meal and a main meal. You do have to have a really powerful blender. It doesn't need to be the really expensive one that's always quoted, the Vitamix. You do get cheaper ones, but it needs to be powerful. You need to choose a blender that can grind ice or nuts. And that's the definition, really, something really powerful. So, progress, so it definitely helps her bowels. There's absolutely no doubt about that. That's the main reason that that was her main outcome, I think. And that's definitely helped. We've had absolutely no metabolic issues. She enjoys her meals, but I think one of the big things, it's just been quite an emotional experience for her mum, going out and buying food, making her daughter real food. We're a little bit stuck at the moment because she doesn't want to involve carers yet. She's a bit anxious if she feels that her daughter is not so well, or if they would have to institute her emergency regime and she was on food, she feels it would be a bit complicated for them. So we're a little bit stuck there at the moment. But that's reality. So these children go in and out of care, and it does make it more complicated. So that's my limited experience. I'm going to probably start my Pompey's boy because I think he would do very well on it. He has lots of issues with constipation, fluctuating with diarrhea. But I think blended diet as a whole, I think if a family asks, you should give it a go. You know, it's not difficult, it is just food. You know, we're dietitians, we can make it work. We monitor, I mean, these are patients we're monitoring anyway, nothing awful is going to happen. I think all diets are adaptable. I can't think of a single diet. They say a ketogenic diet can be adapted to any kind of special diet, and I mean blended diet can too. It isn't for all families because it's a lot of extra work, you know. You have to cook, you have to shop, you have to liquidize, you have to freeze. It does take extra work. It's actually quite messy when you first start till you get, you know, I had a bit hands-on the first child we did, and you just have to get organised so you don't spill things everywhere. And these are children, you know, with a high burden of care. But I personally would suggest that partial blended diet may be an option for lots of paediatric patients and metabolic patients included in that, because it does give you the flexibility just to introduce little bits and pieces, just like you would if somebody could partially feed orally, but if they can't, you've got the option of using blended diet. And this is not the little girl I've spoken about, because that's actually a boy, but he's one of our patients. This is actually a boy who's in foster care, and his foster mum took this on. And he's very, very successfully been transitioned to full blended diet. He's a boy with Ondine's curse, congenital hyperventilation syndrome, who's never, ever fed. And he had lots of issues, and he came off all his... The other thing is getting children off drugs. A lot of them can come off their PPIs, you know, their reflux becomes less problematic. Came off his Movacol, came off lots of other things. And one tiny thing, I don't think, it's not why we do it, but if you get somebody off blended diet, the amount of money that you save on their home delivery order is absolutely amazing. If somebody's in an expensive feed, you'll save between £500 and £800 a month. That's not why we're doing it, but it just shows you what an expensive way it is to feed people on enteral feeding. But what's important is when you get a good outcome, when you get somebody happier and healthier and a happy mum. And I think I've been quite quick. So I'm going
Thank you, that was really interesting. Lots of food for thought there. Did you have any problems trying to get the system set up in terms of governance or any...
In the hospital?
Yeah. Or any objections?
So I think all the nurses and everybody are really keen to do it. I mean, I think everybody can get that emotional bit. So at the moment, we are still just doing it with parents in the hospital. We just say they have to do it, but we're almost at the point of we'll get nurses signed off to do it. But, I mean, these families, if they want to do it, they're there all the time anyway, so it's not really been a big issue. We have also used the Stage C pureed meals, which you can then dilute a bit and use if you're needing. Because, like that boy there, he has like 300 mils at a mealtime, 150 mils for a snack, you know. They need to get enough food into them because you have to get their whole requirements in. So he also, and some of the other families, they can, you know, if he comes back from school or a party with a bit of birthday cake, you know, she'll whiz it up with a bit of milk so you can get the birthday cake in the party bag. And she also gave me a picture of his first Christmas dinner. I mean, it really is really emotional. I mean, the first time I was there when we gave one of the children their first meal, and Dad was videoing it, you know, and I put a little bit in his lips, and then he knew, because he understood what we were doing. He has quite a lot of cognition about food going into his tummy, and he was smiling. But, you know, it really, I don't think you can underestimate that what we take away from families. Mm-hmm. And it is just food. Mm-hmm.
Thank you. Does anybody have any questions?
How long does it take to feed them?
So you would say for, you know, if somebody was getting a full amount, you know, say like 300 mils, just 15 to 20 minutes, just what a meal would take. Yeah, 15 to 20 minutes. Mm-hmm.
Sorry, did I miss? What temperature? Have you got any particular guidelines around?
Just at room temperature.
Right.
When they go to school, we say that the parents usually put a frozen meal in, and then it just thaws out in a chill bag or the fridge over the morning, and it's just fed at cool room temperature. We don't reheat. So cool room temperature.
Yeah.
You obviously don't want to be putting anything too hot down.
No, I was thinking that.
Yeah, no, you have to. There's a lot of practicalities. I mean, I think if you are thinking of doing it with a patient, speaking to somebody who's done it, or the website that most of the parents have gone to, because most of them are American, but there is one that's UK based. This one here, Keep Calm, It's only food. The website's Blended Diet UK, and that was set up by a mum. I think initially when you read it, it was actually how to get dietitians to help you. What to say if your dietitian won't help you, but it's kind of changed a bit because I think that has gone. I think that has gone now. But, you know, massive sort of, lots of recipes. And the families really get into it, you know. They actually feed their children on blended diet probably better than their other children because they you know, they buy it, you know, organic food and avocados and they fortify it with extra virgin oil and Evo. This is not give me a recipe with Evo on it. I wonder if it was, but it's extra virgin olive oil. Evo. But yeah, I think it's not something to be frightened of.
So I was going to say I've only just come into metabolics,
Yeah.
and before that, I've worked quite a lot with children who were on blended diet. So the DISC group, part of the BDA, have done a lot of work on it.
Yeah, there's a lot of work coming.
But one thing I was going to ask is, have you got any that are completely fed on a blended
Not
diet?
metabolic, but we have 5 or 6, I think it's 7 now, children who have completely transitioned. Like that boy I showed you there, he's completely
Yeah, because I was thinking the
transitioned.
difficulty we had was the overnight feeds. Because
If somebody was on an overnight feed, no. So that boy was on an overnight feed. We've just changed. So he has 3 meals and 3 snacks.
So he doesn't have an
No, he's
overnight
nothing
feed any
overnight
longer.
now. I think at least 3 of the ones we did who were, neurodisability, complex neurodisability without a safe swallow. I think 2 of them had an overnight feed before just to get enough into them. But there's something about putting food into the stomach. It behaves differently from a formula feed.
Yeah.
We've actually got a child in the ward just now is being worked up to go home on PN because his intestinal failure was at that stage. But he's tolerating 100 mils of blended diet into his stomach, and he's not been fed into his stomach for years. I mean, it is amazing. It's actually one of the most dramatic things I've done in my career.
Yeah, no, I think it's I've
is
seen some really
actually very-
amazing
and
results.
it's like
But it's
proper-
just the overnight feeding is where
Yeah.
I had some issues because some of the children did still need an overnight
Yeah,
feed,
and
then
if
there's
you do need it, if they can't tolerate it, you just have to do it. I think, fine, you know, a combination partial blended diet. We've got a patient, a little boy, 2-year-old, who's on hemodialysis, and so he has an overnight feed, and he has 2 little feed boluses, and he has 2 little meals during the day, blended diet. So I think it's completely flexible, and I think for lots of families, partial's fine.
Yeah,
just want to
I
give
mean,
them some
you do
food.
get quite a number of families though that actually want to go completely, and then when they want to do when you need an overnight feed, obviously you don't want to be hanging like chicken casserole or whatever it is.
No, I think if you needed an
Overnight.
overnight feed, I would just
Yeah.
use formula.
Yeah,
And quite some metabolic patients will always need, if they can't fast, they will need an overnight feed of formula.
yeah.
But, you know, food during the day, if that's what. I think it's very flexible. Yeah.